Please, Remco, you can go ahead.
Thank you, and welcome all colleagues, friends at this session on the Because Health Conference on Myths and Taboos in Global Health. Welcome, I'm Remco van der Pas, working in Berlin on planetary health, but also a research or a lecturer in global health at the Institute of Tropical Medicine in Antwerp, and a member of the People's Health Movement, the movement that is facilitating today's session about universal health coverage and its discourse. I will introduce the panelists quite soon. To say that we have 50 minutes for this session, so we have to be rather tight in relation to hearing from the panelists. We have a kind of a question and answer session prepared with the panelists that also allow for some interaction with the audience. This session is organized by the People's Health Movement, an international grassroots health professional and academic movement working across countries since over 20 years now already, focusing on comprehensive primary health care, health equity, health justice. So that's the lens with which the participants look at universal health coverage. We decided to focus on universal health coverage, and all these members are part of the thematic circle on equitable health systems from PHM. We decided to focus on universal health coverage because it's now a bit of a set policy goal with the Sustainable Development Goals and for the World Health Organization. But the People's Health Movement has always said that universal health coverage is not the same as universal health care, or it's not necessarily mean comprehensive primary health care. And it's not necessarily equitable or universal in the sense of that everybody can access quality healthcare. So we will unpack that in this session. I'm happy that I'm here with our four panelists: T. Sundraman from the International School of Public Health in India, Mario Esteban Hernandez Alvarez from the Department of Public Health at the National University of Colombia, Jamie Dasmariñas from the Council for Health and Development in the Philippines, Sulakshana Nandi from the People's Health Movement and the Public Health Resource Network in India. From their context, they will reflect on some questions that we have prepared. You can also type your questions or reflections in the chat, and then they can be addressed later on in the session. I start directly already with Sundar, and we have prepared some questions. And the first question for you, Sundar, is, so from your perspective, how do you see the role of governments to achieve these highly contested role in the UHC discourse? What can you highlight from your work?
So on UHC, there is a consensus on why we need it. We need it both for development perspectives and from a rights perspectives. That is accepted. But there is a dialogue that happened initially to a large extent on what this is, on what UHC consists of. An early distortion was to reduce it to just coverage by an insurance program or some very selective elements of primary healthcare universalized. So if everybody gets a package of very minimal selective services, call it universal coverage. Now, this particular distortion, the PHM was to call it out. And in fact, this was one of the important roles PHM played at a time when everybody was going gaga about it. To quote, the Cape Town Assembly, People's Health Assembly, took a resolution where we said, while we welcome the recent upsurge of interest in the concept of universal health coverage, we oppose the idea that this can be achieved through a promotion of a minimalist insurance model that would operate within a marketized system of healthcare, or worse still, be used as a context or excuse to dismantle or undermine public hospitals and promote corporate interests in healthcare delivery. Universal health coverage must be achieved through organized and accountable systems of high-quality public provision. I've quoted this in length because I think it's a milestone to have called this out at that time. Subsequently, this was resisted by a large number of countries and civil society organizations, and these came to a head when the monitoring indicators were being discussed. And World Bank and WHO actually brought out a joint statement when they officially stated that no, we are not pushing for insurance. They are allowed, countries are welcome to make their own roadmaps to achieve UHC. Even subsequently, World Bank has endorsed, at least on documents, the comprehensive primary healthcare approach. Yet, what do we see in the experience of countries? I point out 6 features that are repeated across the countries. One is that there are high-level expert committees set up, usually supported by global health institutions, that make a recommendation for changing the role of the government. And what is the change in the role of the government? The change of the role of the government from a provider of services to a purchaser of services. Free and subsidized care by public sector no longer is projected as a core strategy to achieve UHC. There is a push for insurance schemes with greater attention to somehow engaging and purchasing from private sector. And there is a failure to recognize the repeated failures with PPPs, public-private partnerships, and starting all over again on this issue. So in this context, this entire discourse has been sort of backed by what I would call 6 myths. Myth is a widely held false belief or idea. So one myth is that strategic purchasing works, that purchasing care from commercial providers will be the way. There is really no evidence out there to show, and there are a number of papers that have shown strategic purchasing does not work. Sometimes it is used retrospectively. If it works, they call it strategic purchasing. But generally, as a strategy, it does not work. Second, that private services have greater quality than public services, and only barrier for private sectors is affordability. That's another big myth. Third, public provisioning failure is inherent. So there is no alternative to purchase from private sector. Myth again. Fourth is the only way to reform public provisioning is to introduce market mechanisms into it. Pay for performance, split between provider and payer, introducing user fees or insurance premiums. Myth again. Then publicly funded health insurance programs provide financial protection and cashless care. In paper, they do, but study after study, at least in a number of countries, at best they give some sort of a discount. They don't really provide financial protection. Catastrophic health rates are same. And finally, that primary health care in the LMIC context can be best provided by purchasing care from a network of private providers owned or managed by a corporate agency. There is absolutely no case where it actually has worked in an LMIC. It's a distortion, but this is sort of the push that we have towards corporate power. So therefore, the choice becomes, yes, I conclude between the corporate path or what people's power would have its way. This is the choice before you. Thank you.
Thank you very much for this clear input, Sundar, and setting the scene. I go to Mario Esteban. Mario, and you will speak in Spanish, so people feel free to use the translation as well. What myths, in your case, are amplified in the UHC discourse? Mario, the floor is yours.
Sí,
Usted puede hablar. Yeah.
Muchas gracias. Bien, esta entrada sirve para identificar que el mito más fuerte que hay detrás de esta propuesta de cobertura universal en salud, que viene construyéndose con el neoliberalismo desde los años 70 y 80, es esta idea de que la atención médica, la atención de la enfermedad, es un bien privado que se provee de mejor manera a través del mercado, distinto a bienes públicos que deberían estar a cargo del Estado por altas externalidades simplemente. Esto para retirar al Estado de la provisión directa de estos servicios de atención y entregarlos a dinámicas de mercado por distintas vías. Es exactamente esto de un comprador, un Estado que recoge los recursos públicos y compra servicios en el mercado abierto, o como es en Colombia, que es una forma estructurada de delegación de la administración de los recursos públicos a unos intermediarios privados que se lucran con esa función. Es decir, el sistema de salud colombiano está financiado por impuestos y por cotizaciones obligatorias, es decir, un fondo público, pero se le transfiere a estos intermediarios por pago por persona a cambio de un paquete de beneficios, que es supuestamente alto, y eso hace entonces una regulación de la competencia de mercado entre ellos. Pero de ahí en adelante, este se vuelve el gran agente dominante de ese mercado y obliga a todos los actores a someterse a su control del gasto para obtener rentabilidad. Eso es lo que estamos viviendo en Colombia desde hace 30 años. Es lo que se quiere cambiar con una reforma estructural y no se ha podido porque se ha consolidado el complejo médico, industrial, financiero, global, transnacional, con estos grandes emporios económicos de la atención individual en salud, que se concentra en el mediano y alto costo, alta tecnología, y abandona la prevención, la promoción de la salud, desterritorializa, separa al individuo de su lugar de vida, de sus condiciones de vida, agua, saneamiento, ambiente, para concentrarse en la regulación del siniestro económico que resultaría de la enfermedad. Genera inequidades estructurales, abandona el área rural con población dispersa porque no es funcional al mercado, produce unos efectos de injusticia, digamos, como la mortalidad materna en Colombia, porque no se realiza realmente una atención materna perinatal bien hecha, porque el cálculo de costo-beneficio no le da a este señor intermediario. Esa es la situación. Creo que hay que discutir profundamente el tema de esta separación entre bienes privados y bienes públicos y promover en el debate mundial, recuperar el concepto de ciudadanía social, que es el que está detrás del derecho universal a la salud, más allá de la atención individual de la enfermedad, que es a lo que se dedica la cobertura universal en salud.
Thank you. Okay, thank you very much for this, also to lay out the human rights and the participation aspect of it. Then next, I have Jamie. What is excluded in the UHC discourse from your work and what you see in the Philippines? Jamie.
Hello, can everyone hear me? So good evening from where I'm from. So with regards to the discourse for UHC, very similar to other places in the world, as was discussed earlier, governments have, including ours, have chosen a scheme that makes the government or a facility, private or public, they purchase it for the patient. But what we don't talk about, besides this coverage, which was also how UHC was implemented in our country, is that governance, accountability, and the capability of your local government unit provide care and facilities in the grassroots. They don't really talk about the importance of the roles of such entities. So first off, for example, in where I'm from, our healthcare service delivery in the public sector is devolved. We have a local government code, Republic Act 7160, and what happens is that local government units have to, in terms of healthcare delivery, social services, it's up to the municipalities and the smallest governmental unit, which is the barangay. So what we don't talk about also is that what about accountability? What about corruption, especially in LGU or local government units? It's very rampant, and since the audit from central isn't really tight, what would happen is that it's easier for local government officials to either steal or they have deals with exorbitant prices, but the actual quality of the medications, the laboratories, and the actual services, such as health worker hiring, are not optimal, and it doesn't get to the grassroots. And I think that's one thing we don't talk about in terms of UHC. Does your health financing actually translate down to the grassroots? Do the people that it's supposed to get to actually receive the actual service? So I'm not sure if we talk enough about health budgeting, allocation, infrastructure building, and countries like mine who are very dependent on local government units. So if you have a poorer LGU or a poorer municipality with because the burden of budgeting is also in the locality. There isn't enough budget from the Central Department of Health in our country that is given to the locality to make sure that everyone, whether you're from a geographically disadvantaged and isolated area or in an urban setting, would you both still get the same kind of care, whether if it's public or private? But another unique setting, I think, is at least in our setting in the Philippines, in poorer municipalities, and the farther away you are, people are more dependent on public facilities. But even if you have 100% coverage for PhilHealth, your health insurance, if the locality doesn't have
I think it's a bit shaky, I hear, but I understand that it's really about decentralization and not having the funding locally available so that it doesn't reach. You have low quality of care despite there being coverage. That's very clear. Thank you, Jamie, for making that clear. Sulakshana, you have been studying this for quite a long time now. Looking at this, what is the impact on health equity and financial protection in the cases that you have studied?
Yeah, thanks, Remco. I have so hello everyone. I want to share some of our experiences from India in terms of equity and access and financial protection. So we have a prime Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, and which basically in 2018 expanded the previous insurance scheme in terms of the coverage, both financially and also in the number of people that they are covering. However, when we find, all the studies and have found that, the coverage in that sense may have increased, or, there may be more people and who have insurance, even though there have been exclusions because, it requires citizenship IDs and various biometric cards, which are, often for very vulnerable populations, for migrant workers, for transgender people, it's very difficult to access. Secondly, the data also says that utilization has increased in some instances. However, it has been highly inequitable. So based on geography, regions where you live, rural, urban, your social groups, the tribal populations, your caste position, your class position. So there is inequitable utilization. And we find that this whole the law of inverse care, in the sense that where the most vulnerable regions, or the regions with the highest with the most need end up being neglected and undermined. So a higher proportion of the claims go to the for-profit private sector, which are urban centric, and the public hospitals or the public sector that is actually catering to people in, within marginalized communities, women and others from poor rural tribal communities are, getting, the public sector is getting undermined because we have nearly more than 75% of the money going to the for-profit private sector that is in the urban areas. The other is the comprehensiveness of services that Jamie also pointed out. So you find, that there is selective services that are being provided and also a pattern of unnecessary surgeries. We had this whole, number of cases of cesarean section, etc. So basically you find that there is pooling of funding. However, with unequal services, because you're not simultaneously strengthening the public sector and actually underfunding the public sector, it really results in poor districts and populations subsidizing the better off. And the biggest finding, from all the studies has been that, such schemes, the insurance schemes, have not led to cashless services, and out-of-pocket expenditure continues, which is a huge burden on poor families, tribal families, families and communities that are supposed, that should have benefited most from any such, that are set to, these schemes are promoted in their names, but, there is very high out-of-pocket expenditure, and families also face a lot of abuse and harassment. And, the power that is there within the for-profit private sector with the doctors, it's very difficult, in that negotiation to, to assert your agency, and studies have shown that, families assert their agency, but after a point of time, they also are helpless, and, the hospitals really take advantage of them. So most for-profit private hospitals continue to charge extra, despite, this being a cashless scheme. And it's basically a case of coverage without financial protection. And we saw this even during the pandemic, at a time of crisis, when the public health insurance scheme should have, really ensured that there is no catastrophic expenditure and should have responded, and the private sector should have responded, in a more equitable manner, but however, that wasn't the case. And in India, we saw that actually, being insured under the government scheme was not effective, in reducing out-of-pocket expenditure or catastrophic health expenditure. And the utilization of for-profit private hospitals were basically the main determinant of incurring catastrophic expenditure for COVID and non-COVID treatment. And just to end, I think colleagues had also brought up this issue of governance. So I think that also has it is very important when we talk about equity. So these new, governance structures that have come up that bring in the corporate, parties into their boards. In India, we have the National Health Authority, and it's like a quasi-government entity with with private people in the governing board too. So and which is sort of parallel to the Ministry of Health. So the issues of accountability and governance also are really things that are concerning, and also transparency. At this point of time, if you want any data from the National Health Authority on PMJY, you and I will not be able to get it. Of course, the World Bank gets it, BMJF would get it, or USAID might get it, but not the public whose money is being spent on this scheme.
Okay.
Yeah, thank you.
Thank you, Selekshan, to highlighting that also from a out-of-pocket expenditure, there has not been advances despite all the promises. So also to be clear, to all, the participants have all prepared also presentations and provided some input. These will all become available as well in the Because Health website. There is some documents and sources also being shared in the chat. And the People's Health Movement would not be the People's Health Movement also not by looking forward what could be alternatives. So this is the second question I have all to you. So how can we overcome this gridlock? What will be alternatives? What have you done in your context to make a change? I will go around the same round. Sundar.
So I think one important role that we play is first and foremost, do not let people forget the past. You know, I get very irritated when the development partners will come and suggest public-private partnership as if it's a new idea that is just being born and has to be tried for the first time. There are 25 years we've been trying it and it has not worked. But quietly, people tend to forget the past failures and the reasons why they failed. So keeping that memory alive of experience, or the World Bank comes and talks on the lack of comprehensive care without owning up to the fact that they drove selective primary health care and were causative for this change. So I think retaining public memory on some of the changes of policy is an important role. The second thing is really providing evidence, and these things come up in a moment of crisis. This whole thing of moving into purchasing from private sector, the number of contracts, the number of all the talk, when COVID-19 pandemic struck, finally you had to fall back on the public sector. Well, the whole of the private sector was actually shut down for a number of months, and even when it started in an extortionist way, it had to go back to this. So, and then this has to be presented by testimonies, but these are also, you have to have studies that keep debunking many of these myths. One has to do it again and again. But the third, and I think this is something that we have also focused quite a lot on, is building of alternatives in terms of strengthening public sector. Public sector alternatives, we don't even have quite a good theory by which we can look at non-market-based alternatives to strengthening public service delivery, or what I call the mere enforcement options. This is not happening. It should be made to happen. It's only a disciplinary approach that people talk of. You don't talk of creative and innovative solutions to the problems of healthcare delivery in the public sector, and therefore you tend to justify that there is no alternative approach. So articulation of the alternatives, like for example, what we did with the community health worker program, what we did with different forms of community monitoring by civil society, what we have done in terms of being able to support a number of and demonstrate new innovations in pilot programs. These are all very important to be able to build a case for a better health system. Thank you.
Thanks for this. Alternatives are possible. It's important that you mention it. Mario, up to you.
Sí, muchas gracias. Creo que en eso coincidimos todos y todas. Aquí hay una necesidad de movilización social por la salud en un sentido amplio, no solamente la atención médica de la enfermedad. Al contrario, tendríamos que construir, por eso, esta idea de lo común. ¿Qué es lo común en medio de la diversidad? Diversidad cultural, territorial, política, económica de nuestros países, pero buscando esa construcción de lo común. Lo común en salud tiene mucho que ver con el buen vivir, tiene mucho que ver con las maneras en que las mismas comunidades, las sociedades, construimos diariamente nuestra buena vida, una manera, un sentido de vida, y no solamente la atención de enfermedad. Pero esa atención de enfermedad se puede organizar efectivamente de una manera colectiva, de una manera universal, con un sentido de lo público que implica también debatir sobre la relación Estado-mercado en la garantía de los derechos humanos interdependientes, individuales y colectivos, si lo queremos llamar así. Y por eso el elemento central allí es esta idea de ciudadanía social, por un lado, pero también de reconocimiento de diversidad, diversidad humana en todo el sentido, pero también diversidad en la relación sociedad-naturaleza. Implica reconocer formas de vida que son alternativas al desarrollo y no de desarrollo. Eso quiere decir un nuevo proyecto civilizatorio que no pasa por el capitalismo financiarizado, cognitivo, patriarcal, racista, ¿cierto? Que extrae todo el tiempo renta de la vida toda. Ha convertido la vida en mercancías. Y tenemos que superar esa lógica mercantil y recuperar más bien el sentido común de la vida. Y eso implica movilización, articulación en lo local, en lo nacional y en lo internacional. Creo que People's Health Movement, el movimiento, es muy importante en ese sentido. Y hay plataformas similares en todos los continentes, en todos los países y regiones. Deberíamos entonces buscar la articulación estratégica de esas plataformas para generar procesos de construcción de lo común en salud desde experiencias concretas, pero también desde la disputa internacional, global, por la orientación política de la salud en esta crisis civilizatoria que vivimos.
Muchas gracias, Mario. Reclaiming the commons and a common approach to health beyond selective universal health coverage. Jamie, the Philippines, what have you been doing there to resist?
So to resist, we've already, this is our second attempt filing for an alternative bill in opposite to the current universal healthcare law that we have. So House Bill 208 is a bill for a free, comprehensive, and progressive public healthcare system. So as I have discussed earlier, we have pushed for a greater government accountability, especially after COVID hit us, because our country was really not prepared. Baseline already, what the UHC law of 2019 did was just strengthen PhilHealth without strengthening the actual health service providing aspect in the grassroots, especially for primary care. And besides direct funding for operational expenses, healthcare worker hiring, and procurement of medications and laboratories, what we'd also want would be, we're also actually pushing for renationalization of our healthcare system, that hopefully it won't be very dependent on the local government units that have an easier time with corruption and so on and so forth. So the money doesn't go where it's supposed to. And more importantly than that, service does not reach the people. And that's one thing that we have always been saying, but it feels like this really long stretch of both propaganda and actual lobbying in Congress, as majority of the stakeholders and the movers within communities of lawmakers are still very supportive of the private sector. But the thing is, if you only bolster your national health insurance, and it's just there, it's a lump sum of money that people only use or get to use when they have something, or they try to avail of the care that they need. But if the actual public sector health providers do not have the capability to do that, we will have another tragedy like what happened in COVID, that it all went down to who had enough purchasing power, who had enough money for out-of-pocket expenditure, and that determined who got to live and who would die. And of course, if the poorer you are, your chances of living, especially in a pandemic, they would drop. And that's something that we do not want. And hopefully, governments, not only ours, would realize that you are supposed to strengthen your primary or first touch care, especially if it's more of on preventive, not just primary. And it does not start with strengthening just a national health insurance. It has to be translated to actual services that people can feel and actually access whenever they need it. And of course, they don't have to pay extra because they already pay for it in taxes. So there.
Thank you. And the accountability there and involvement of people and That's very important, and I think that's what you are doing in the Philippines. A much important task. Sulakshana, you've been written in the past about UHC, primary healthcare. One step forward, two steps back. How can we reclaim our steps? What to do?
So, I mean, I would like to sort of divide it into what governments need to do and what civil society needs to do. And I think, I mean, just in addition to whatever my comrades have said before me, you know, I mean, I think, you know, when we talk about evidence-based policy making and we tell government that you need to do that, but along with that, you know, I think democracy is very important. Democracy and an interest in actually improving people's lives. So I think so it is actually finally a struggle for political change. It is a struggle for social change. So that's one part of it. Then the other thing is, you know, governments and governance bodies need to act on conflict of interest. You know, we are seeing this not only within our countries, but within global institutions. We have multi-stakeholder, you know, arrangements that are really, you know, undermining multilateral institutions and also, you know, promoting a lot of this kind of for-profit engagement within countries and also globally. The other thing, and of course, you know, finally, I think all like everybody else talked about, you know, I mean, governments need to strengthen public sector provisioning, and it can be done. We have enough examples, and it's very important for all of us to document those examples. And you know, I mean, people talk about Thailand as a UHC UHC sort of model. However, you know, the model in Thailand is so different from what we you know, see in India or in the Philippines, because, you know, Thailand model is predominantly based on the public sector provisioning. Therefore, unless the governments increase the public sector provisioning, things are not going to change. And for that, deprivatizing, remunicipalizing is again something that a lot of governments have been doing, including in my state. There was a tertiary heart institute that was deprivatized, and the impact on financial protection and on equity, you know, we documented that, and we can share it later. So as civil society, like Sundar said, we need to remain very vigilant. And, you know, we can see, for instance, you know, the kind of discourse and the kind of building of the narrative for the universal health coverage is happening similarly in the last couple of years with primary health care. And that's something that we really need to be vigilant about. Document and record failures and successes, examine and critique such dominant narratives that put profit over people. And, you know, and in our countries, we demand higher investment and strengthening of the public sector. The Jan Swasthya Abhiyan in India is very much, you know, part of the campaign of strengthening public services. And we've had a lot of successes in the past, and even like yesterday, there was a right to health bill that was passed in Rajasthan. In Chhattisgarh, the government announced that, you know, they're going to abolish all user fees. So we do have some successes. However, it is really important to build solidarities across movements, across academics, across activists, and, you know, and that's where sort of a forum like the BCOS conference becomes very important, because you have practitioners, activists, academics coming together, and I hope we can continue this engagement. And yeah, and I think Remco will speak about PHM and invite you all to join. So yeah, thanks.
Thank you very much for this. Also to strengthen the movement, and that the democratization part is an important element of health system development, and that's often forgotten. The good thing is we have quite some minutes left for interaction with the audience, about 15 minutes that we can spend. So I ask people to raise their hand if they would like to speak, or they can speak out directly as well, or write in the chat to have a question for the audience, or just to give your idea or from your context how you deal with this UHC challenge, and what you think is needed to strengthen care and how to finance it. Who would like to speak from the audience?
Remco, there's a question on non-profit private sector that if there is time, I can just respond on the chat.
I saw that, yes. It's the question from Isabel talking about private sector problems making the problem. If the problem is making profit, why should we not focus more on the not-for-profit private actor? Isabel, if you're in the room, would you like to clarify that question or expand on that? No, I would suggest that we keep that question. There's also another question from Marilyn. Marilyn, would you like to raise that directly?
Sorry, it's actually not a question. It's more of part of our the activities that we do, because there was a question earlier as to what we in the development NGOs can do, and as part of our advocacy, we
can you sorry can you speak within the microphone?
Yeah, I think the mic is covered.
Yeah.
Oh, sorry. Yeah, is it better? Can you hear me now?
Much better. Yes, Marilyn.
Okay.
Marilyn.
Yeah. Thank you. No, it's what this is actually in response to the question earlier about what we can do in the as part of this civil society organization. So in our advocacy work, we were able to approach some of our legislators and ask them to file a bill to prevent the privatization of health facilities and especially public hospitals, because in the Philippines that has been ongoing for the past several years. So that's I think since the turn of the century, since 2000, we already have facilities that have been privatized, and it's still ongoing. So hopefully the bill will we will succeed in having that bill filed and go on to the Senate and approved, but it's of course there's still a long way to go in terms of advocacy work and mobilizing and getting the support of other legislators for bills such as this. Thank you.
Thank you also for this, Marilyn, and clarifying also that there's a legislative and juridical path that can be followed. I see that Joel Ekofo has raised his hand. Joel, the floor is yours.
Yes, thank you. I want to speak in French, please.
C'est possible. Il y a traduction.
Bon, merci. Je voulais partager en fait l'expérience de la République démocratique du Congo en Afrique. En fait, depuis un moment, nous aussi, nous avons notre pays, le gouvernement de la RDC, a opté pour la tarification forfaitaire afin d'atteindre en fait la couverture de santé universelle d'ici 2030. Cependant, quelques expériences, nous nous sommes inspirés de quelques expériences de la tarification forfaitaire mises en place par certains partenaires, notamment MEMISA Belgique, la Banque mondiale à travers le programme de développement du secteur de la santé. Mais il se pose un problème parce que, comme vous l'avez dit, bien sûr, en RDC aussi, la plupart des structures des établissements de soins de santé sont des structures privées. Et du coup, lorsque ces partenaires, ces expériences sont mises en place, on tient plus compte aux structures publiques. Et lorsqu'on tient compte aux structures publiques étatiques, il arrive que les malades, les patients, quittent les structures privées qui sont majoritaires pour aller maintenant se faire soigner aux structures étatiques. Et là, lorsqu'ils affluent, lorsque leur quantité, lorsqu'ils sont nombreux, on ne parvient plus, les personnels des structures étatiques n'arrivent plus à offrir des soins de qualité. Mais également, il se pose aussi un problème de pérennisation de ces stratégies. Une fois que le financement prend fait, c'est fini, ça tombe. On revient à l'ancienne méthode de paiement direct par le out-pocket. Et là, on n'arrive pas, on ne sait pas. Et même l'État, parce que la plupart du financement de la santé, la grande partie en RDC vient des ménages pauvres, bien sûr. Et d'autres parties, après le ménage, c'est plus les partenaires extérieurs qui viennent appuyer les secteurs. Le gouvernement ne met que moins de 10%, alors que nous devrions attendre, selon l'accord d'Abuja, 15%. Alors, on ne sait pas comment est-ce que nous allons sortir de cette situation. Il faut d'un côté aussi intégrer les structures privées lorsque vous mettez en place ces stratégies, et de l'autre côté aussi la rationalisation, l'utilisation efficace et rationnelle des ressources mises en place pose problème. Voilà un peu, et il y a toujours eu des questions là-dessus. On attend, on est en train de voir dès l'année prochaine et cette année, le gouvernement essaie un peu de mettre en place la gratuité des accouchements et puis des soins des nouveau-nés. On verra comment est-ce que ça va donner et ce que ça va donner pour qu'on puisse continuer. Voilà. Merci.
Thank you very much. It says something about sustainable financing and domestic resources and international resources to make essential healthcare possible at all. Huh? So that's the interdisciplinary and intersectoral debate with the financing that we need to continue. There were people, feel free to speak up. If you have a question that is possible. I'll look around. I always encourage people to share their thoughts. I see Jamie want to raise her hand. Jamie, go ahead.
Hello. So I noticed that there's been a lot of discourse regarding the private sector involvement. And I think a common problem is in terms of accountability. In our context in the Philippines, what we really noticed is they're very profit driven, and that goes against what we want in terms of access for everyone. And I guess that's one very important point of debate, especially for policy making and when we engage with the private sector, up to where can they demand in terms of profit, or will we even allow it if we're going to involve them in actual healthcare delivery? And that's what Thailand did, that even their private sector was under the umbrella of the public sector per se, so they could control what expenditure would be taken from the public in terms of out of pocket, and they actually could compete quality wise, I guess, and coverage wise in terms of actual healthcare delivery. And that's something all countries need to discuss, especially if we don't want another COVID-19 part 2. And hopefully we will not have another COVID-19 part 2, but it all comes down to accountability. So
thank you for clarifying this, the role of governance and regulation, and for the public sector to have the capacity to do that. I think that Sundar also wanted to react to the question on the not-for-profit sector, whether that would be an alternative and what role they have in universal health coverage.
So I think it's important to say that the participation of not-for-profit sector is welcome. In a sense, they are public by other means, that they are not really going for a profit motive. And I think we should welcome that. But there are 2 or 3 problems. One is they are generally not available on scale. So where there is a good unit, you can make use of it. But the coverage in many places is less than 5%. There are a few country exceptions, Bangladesh, for example, but generally not-for-profits is very good. Second, you still need government administration and payment. If you are going to really base it on fee-for-service mode, then all the problems of fee-for-service appear. There is an over-consumption of unnecessary care, and there is the exclusion of the poor. We have very many good not-for-profit organizations who can't be pro-poor and be sustainable. So they are either pro-poor or they are sustainable, unless there is a subsidy element that comes in from the government. So therefore, to actually, while good not-for-profits should be incorporated, to build a system around not-for-profits is not really possible. You do need and there's just not enough of them around in most places. I think that's my take on that. Thank you.
Thanks very much. I'm looking around. If not, I'll ask also Mario and Sulekhana still to provide their thoughts based on what they've heard, and some key messages also to move things forward. Mario.
Sí, muchas gracias. Pues creo que hay un elemento fuerte allí que hay que entender mejor, y es la consolidación del complejo médico, industrial, financiero, global, que es muy poderoso, muy poderoso, gobierna los organismos internacionales, los estados, bueno, los mercados en todos los países, y esa fuerza se opone a cualquier propuesta de reforma. En Colombia estamos tratando de hacer una reforma estructural que recupere la administración pública de los recursos de manera descentralizada y ordene las redes de servicios por atención primaria. Y es casi imposible. Ha habido todo tipo de oposición, incluso de muy mala calaña, muy mala perspectiva. Así que hay que hacer conciencia del poder global del complejo médico-industrial, y tendríamos que construir estrategias que disminuyan, que contrarresten ese poder como movimiento social por la salud de carácter global.
Yes, and also it is one of the biggest growing economies in the world, the healthcare economy, and that needs to be understood properly, that there's a lot of commercial interest there, and that we need to counter. Sulekhana.
Yeah, thanks, Remco. So just continuing in that vein, what you just, Mario has also said, and what you said. So, I think, I mean, this issue of profiteering, and UHC, I mean, the schemes, the health insurance schemes that are being promoted in the countries are very explicitly being promoted as business models, and I mean, they use these words, so it is meant for profiteering. And I mean, there's a tweet by the National Health Authority ex-head, urging all eligible private hospitals to empanel with Ayushman Bharat. We are offering you business of 50 crore people. So, I mean, so that's how they are attracting the private sector. So I think this whole issue of commercial determinants of health, and that, health being a good, I mean, it's not a bad thing. Health is a good thing. But within that, the commercial interests, when they enter, and, what implications that has on health, I think that's how we really need to understand even the UHC implementation, and what is happening. And in fact, just from today midnight, there'll be a series on the Lancet series on commercial determinants of health, which is going to be published later tonight. And there also, actually, I mean, in one of the papers where I've contributed to, I've tried to develop this idea of how, I mean, this is all within, it is a commercial determinant of health, along with your big pharma, big food, tobacco, alcohol, the commercial healthcare sector, the commercial hospitals, these also make up, the commercial determinants of health. So I think that's very important to understand, and at each level, we really need to keep campaigning, being vigilant, and documenting and resisting all such efforts, because finally it is the public sector that is going to be most sustainable. And it's not only a matter of the kind of health services, the comprehensiveness that is provided by funding the public sector, public clinics or primary healthcare clinics, your public hospitals, your tertiary public hospitals. All through it's also like public employment. So in countries like ours, in LMICs, we need government to bring in more public employment, and we need governments to recruit more health workers at all levels. And so it's not only good for the health, health in terms of a biomedical sense, but also for society, for social equity, for social justice, and for sort of a healthy way of being in this world.
Thank you all to making this clear, and also that at the moment healthcare systems in this privatized mode can become a commercial determinant in itself. To say, and maybe you can go one slide back, Jasper, that this discussion is being held for a while, will continue at the People's Health Movement thematic group on equitable health systems. We're campaigning on it. There is learning and campaigning across countries. That Health for All campaign, both at the international and at the local level, will continue. We're involved in education and teaching via the International People's Health University. We are very open to new members and to engage you in this discussion, to do research as well. Sulakshan as a coordinator, you see the email here. And let me say that while we're moving, there will be a high-level meeting on universal health coverage later in the year in New York. It's 4 years after the first one, and it's time now also to call it out what it is, that this way of approaching it is not working, and that we find alternatives, and that there are alternatives based on the original primary health care thinking from Alma Ata, but that we need to find equitable finance models and have international solidarity and responsibility there. The material will be available via Because Health. Do email us also if you would like to have that material. I like to thank Jasper from Viva Salute on the background in making it also possible that we shift through the slides and see the panelists. It was excellent. Thank you also for keeping time and that we have this great exchange. And looking forward to working together on this. See you soon, somewhere, sometime. Bye-bye.
Thanks. Bye-bye. See you.
Thank you.
Bye.
Thank you, guys.